Hello, and welcome to Sumis Medical Laser interview series. My name is Betsy Ferg, and I am the Marketing and Creative Director for Sumis Medical Laser. I am very excited to introduce our esteemed guest to you today, Dr. Praveen Arany. One of the world's leading experts on oral mucositis, he has published over 80 scientific papers and is the recipient of numerous awards. Not only is he trained as a dentist and an oral pathologist, he is also a Harvard Presidential Scholar. Currently, he is an assistant professor in the Oral Biology and Biomedical Engineering Department at the University of Buffalo. He is also president of the World Association of Laser Therapy. Thank you for joining us today, Dr. Arany.
I'm Praveen Arany. I'm a dentist and an oral pathologist by training. I did my advanced training and got my doctoral research on photobiomodulation. I basically am very interested in trying to understand how photobiomodulation works. We all know and have heard so much about this treatment. My primary clinical research goal is to understand how light, a physical form of energy, can change our human body. And that's been the focus of my research. I guess our claim to fame is that we have found one of the molecular mechanisms that is responsible for converting light, a physical form of energy, into a biological signal that is capable of healing. And our research, our basic lab research, our human clinical trials are all focused on trying to apply this knowledge to improve clinical care.
Let's get started with the basics, with defining oral mucositis. Dr. Arany, what is oral mucositis?
So oral mucositis is defined as the name suggests, oral meaning affecting the oral tissue, and mucositis meaning inflammation of the mucosal lining. And that is in a catch-all term, the name itself represents the disease. Oral mucositis presents as pain, inflammation, redness or erythema, as well as in the worst cases, there will be a complete breakdown of the mucosal lining, resulting in wounds or ulcers.
I understand that oral mucositis is often the side effect of cancer treatment. Can you tell me what the prevalence of oral mucositis is in cancer patients?
Oral mucositis can occur independent of chemotherapy. So there are various causes of inflammation of the mouth. As you're a practicing dentist, you know there are several mechanical and biochemical as well as microbiological effects. Mm-hmm. What happens when you give patients cancer therapy, whether it's a bone marrow transplant, whether it's chemo or radiation or combination thereof, you reduce the ability of the human body to fight normal stresses. It could be mechanical stress of eating, it could be having hot or cold liquids. So this combination of reduced resilience in the patient because of the chemo treatment or the radiation treatment, along with our normal mechanical or biological activities, results in inflammation of the lining. People have documented that with normal chemotherapy, which is for solid tumors, the incidence of oral mucositis varies between 20 to 40%. With high-dose chemo, this rate, unfortunately, is as high as 80%. The worst of these are actually among head and neck cancer patients who get radiation, where people will pretty much say at some point during their treatment, almost 100% of the patients will have some level of mucositis. Some very mild, as in pain or inflammation, and some outright ulceration and wounds.
So it sounds like oral mucositis is not only a very prevalent side effect of cancer treatment, but it's also very painful. Tell me, what can we do for these patients that have oral mucositis? What are the treatments that are available for it?
So most of the treatment currently are palliative. They are empirical in terms of trying to reduce the pain or inflammation, either using analgesics or using antihistamines, or even simply coating the surface with a gelation agent, right? Like cellulose or other forms of polymers or substrates that prevent contact from the oral mucosa. Now, all of these are palliative and are symptom-directed and are empirical by nature. They are not trying to target any particular process. At the very high end of these treatments, and this is in the last decade, there has been a lot of exciting work with keratinocyte growth factor, KGF. Now, this is a targeted therapy which specifically is trying to accelerate the mucosal lining to heal itself. And it works really well. It is an expensive drug, but it works really well. And that has limited its use in the general population. Photobiomodulation, in contrast, is directly addressing pain, inflammation, or the lack of healing due to multiple molecular mechanisms that have been outlined in the past decade.
So it sounds like laser therapy is a viable option for oral mucositis. Can you tell me what the mechanism of action is for photobiomodulation?
So the use of low-dose light treatments is termed photobiomodulation. And as the name suggests, photo meaning light, biomodulation meaning modulating the biological response. So photobiomodulation, or PBM in short, is also referred to as low-level light treatment or low-level laser therapy, LLLT. This is the older terminology, and now we use the term photobiomodulation because it better represents its biological response. Photobiomodulation or low-level light therapy or laser therapy directly addresses the underlying pathophysiology of oral mucositis. Now, if you look at oral mucositis, you see that it's red or erythematous in appearance. It is painful, and usually at the severe level, you have lack of healing or ulceration. Photobiomodulation has been shown to specifically target anti-inflammatory pathways as well as pro-healing pathways. Some examples of these pathways include TRPV1 receptor for pain. Photobiomodulation has been shown to reduce this pain transduction and therefore relieve pain directly. There is also evidence that photobiomodulation is capable of modulating anti-inflammatory pathways such as NF-kappa B, as well as promote pro-healing pathways such as TGF-beta1. Transforming growth factor beta-1 is a central factor responsible for promoting tissue healing and regeneration. And there is now direct evidence that photobiomodulation, light treatment, is capable of stimulating or modulating these pathways.
Tell me more about the direct evidence, Dr. Arany. Is there research out there to show that PBM is effective?
So this is a good segue into where the evidence is for current clinical use. The Multinational Association of Support of Care in Cancer and the International Society of Oral Oncology have done a recent systematic review and meta-analysis, the highest level of clinical evidence, right? Based on 33 well-done randomized clinical trials, and have outlined the evidence where photobiomodulation has been shown to have the highest level of evidence, level 1 evidence, in prevention of oral mucositis, especially with chemoradiation combinations, as well as bone marrow transplants. In other forms of cancer therapy, such as chemotherapy alone or a low-dose chemotherapy, these evidences are at a lower level of significance. Nonetheless, they have shown clinical benefit. So one of the conclusions of these studies is that we need to be doing more robust, rigorously done photobiomodulation parameters with uniform devices that are capable of promoting healing. And as you will see from this paper, unfortunately, because of a broad range of possible parameters, it has not been possible for that organization, MASC and ISO, to recommend a specific protocol. On the other hand, the World Association of Photobiomodulation, of which I currently serve as the president, is currently putting together a position paper suggesting several specific photobiomodulation protocols, including treatments with LEDs, with lasers of different wavelengths, as well as both intraoral and extraoral treatments. These are the questions we always get when we talk about photobiomodulation. What device do we use? What wavelength do we use? What dose do we use? And how do we use it? I would like to, and again, I'm sure there are going to be very specific questions, but before we leave this topic, I'd like to emphasize that while there are several different studies that have shown clinical benefits, some to a greater extent than the others, what we know for a fact is that this treatment is extremely effective in preventing oral mucositis.
Really great to hear you say that. Tell me, in order to prevent oral mucositis, when should a patient be treated?
We in the field now have begun to think of mucositis due to cancer treatment as an injury that we cause the patient. An injury we are trying to do to protect the patient from the tumor burden. Unfortunately, these patients are subjected to the side effect of mucositis. So if you look at our current recommendation, we are recommending the use of photobiomodulation to prevent mucositis actively. This is even before you get chemo or radiation. And we suggest doing this 30 minutes to an hour before treatment. That way, giving your body the best chance to fight this new injury due to chemo and radiation. So the ideal protocol, which I think will lead to a reimbursement question and who gives this treatment, the ideal protocol currently that Walt is recommending and many other investigators are recommending is that the patient be treated 30 minutes to an hour before they get chemo or radiation. Now, just thinking about that logistic, we have done several cases now, case reports are already published and available, where logistically this would not be possible unless you have a dental unit or a head and neck unit within the hospital that does cancer care, right? So the other alternate, the patient is seen as soon as possible, either before or after treatment. And the time lag is not critical, but ideally it would be within 30 minutes to an hour before they get chemo or radiation. On the other side, if patients present to the dentist or the dental unit with ulcers in their mouth, they should be treated immediately. And again, we believe that, and I think the field agrees, that there's a slightly different protocol that will promote wound healing compared to a different protocol that improves resilience, right? These patients are going to be traumatized by the cancer and chemo for a good reason, but nonetheless, they are going to be traumatized. And we are able to prevent that unfortunate side effect and improve their resiliency to get this treatment.
Dr. Arany, should patients be treated in a preventative manner or an active manner?
We strongly recommend doing prevention, and the evidence points towards, at the very least, reduction in the severity of oral mucositis. So if you look at the studies that we reviewed, we showed that most patients do not get, who usually would have gotten grade 4 or grade 3, are getting grade 2 or grade 1 mucositis, which is great because it improves their quality of life and their compliance and their completion of treatment. So we strongly recommend doing prevention, and unfortunately, if they present with oral mucositis, then you can supplement that with treatments.
So in summary, it's important to treat in a preventative manner to prevent the oral mucositis from occurring, but if it has occurred, then you'll treat in an active manner. Okay, so the next question is, should you treat extraorally or intraorally?
The question about the extraoral versus intraoral is perhaps most relevant to our pediatric populations. You can imagine that the compliance for someone opening their mouth for a long time is not going to be very good. And this we have seen with several bone marrow transplant, stem cell transplant patients, where folks have preferred using an extraoral technique to improve compliance, especially if you're doing it preventively. We have also noticed that people who do intraoral treatments for photobiomodulation usually have restricted mouth opening, and should you contact the wound or the ulcers, it is painful. So there are nuances to clinical delivery, but I would emphasize that both extraoral and intraoral photobiomodulation has been shown to be effective. You have to know the dose and the device that you're using well, and you can do effective treatments.
Dr. Arany, you made a very good point about knowing your doses and your devices. So where can dentists learn about how to use photobiomodulation and therapy lasers?
Education in photobiomodulation or low-level light treatment is unfortunately not organized well. We do rely on our commercial partners who are selling devices to at least give them device-specific information. And usually they also do a great job of bringing in people who can do foundational introductions to the subject. What would be ideal specifically to a dental audience is being exposed to the fact that light can be a tool besides a cutting surgical approach. And that's where education in lasers in dentistry is becoming very popular. And our institute at the University at Buffalo, as well as several institutes around the country now, have very specific lasers in dentistry curriculum that are expanding at the pre-doctoral level, at the basic dental training level, are expanding beyond surgical lasers to non-surgical applications, such as photodynamic therapy and photobiomodulation. These are things that now are considered scientifically validated, and there are several devices already available on the market. So it's only a matter of time before this becomes a routine part, as it has become at University at Buffalo School of Dental Medicine as a part of the dental curriculum. If you have not been exposed to this area, a great place to start is with devices, because I think all of us as clinicians not only want to learn about the topic, but we also want to use that device. And that is where I think a partnership between such as this, where we are having a webinar, where we are combining academic and commercial partners to provide the information, will bridge that gap before it becomes routine care. I have one more thought on this before we leave this topic. So when we talk about lasers in dentistry, we always think about, I'll give you a good example. So when we learn about radiation, we are usually thinking about radiographs, right? And to some extent, we also learn about radiation treatment in cancers. Not that as dentists we'll ever do that, but we know that it can be used as a tool. But we do intimately understand radiation and radiographs because that is our bread and butter or daily use in clinic. We are never exposed to light as a tool. We never learn about light as a tool. Nothing in medicine, nothing in biology, or in dentistry specifically talks about light as a tool. So that is where we have identified a major gap in our knowledge. And just like we would not teach people, different burr designs or different curettes or scalpel blades without telling them the biological context, education in photobiomodulation and lasers in dentistry as a large must focus on the biological aspects. You need to understand what happens when light enters the tissue, whether it's a surgical treatment or a non-surgical treatment. And that's where there is a gap. We learn about, most laser courses now talk about Einstein's theory of stimulated emission of radiation, and it talks about how lasers are built, diodes or gas lasers. But unfortunately, they don't go to the extent in terms of light biological tissue interactions, which is becoming more and more important as we differentiate between surgical treatments and non-surgical treatments. I will emphasize again, photobiomodulation is a non-thermal, non-surgical technique.
Talk to us about insurance coverage and medical reimbursement with oral mucositis.
Right. So if you look at when is there adequate scientific evidence for something to become routine clinical practice, we have to go back to our roadmap. And the roadmap, the pyramid of evidence, at the very pinnacle is systematic review and meta-analysis, right? When you read a systematic review and meta-analysis, such as, especially in a prestigious journal such as Journal of American Dental Association or New England Journal of Medicine, something at that level, or Lancet for that matter, you will see that people do very rigorous analysis of multiple randomized, blinded, placebo-controlled clinical studies before they make this recommendation. Once they make the recommendation, it is up to the professional body to certify these as clinical practice guidelines. And that is where photobiomodulation has not made that leap yet. Nonetheless, we have approached both the American Medical Association and the American Dental Association and provided them this evidence that photobiomodulation is extremely effective for oral mucositis. We have also had independent conversations with several insurance especially the medical or the scientific groups, including the Blue Cross Blue Shield group, United Health, Kaiserslautern, and several others. And the whole idea there is to provide them this information, and they do their own diligence, whether it's ADA, whether it's AMA, or any of the insurance groups. They will now take this information and go back to their medical groups and then make a determination on whether this should be reimbursed. Given the evidence that we have, we are very confident this is only a matter of time. What that exact reimbursement code will include is debatable and open for, I think, further discussion. I see several other questions that you have, that who is going to provide the care? What kind of treatment regime are we talking about? Are we talking about treatments every day, 5 days a week, 6 days, 6 weeks in a row? Or are we talking, treatment-based reimbursement? So that, I think, will be debated, but we are very confident that we will have a code very soon. I will say that our conversations with the insurance, I would say experts, medical experts at the insurance agencies have begun to think about it as bundled care. This is a side effect of the treatment that the physician is providing. So this is something that we induce in our patients to protect them from the cancer, but it's an unfortunate quality of life issue. It can be, besides the significant morbidity in terms of nutrition, in terms of health, in terms of depression, all of these can be mitigated by this treatment. But most importantly, grade 3 and grade 4 mucositis can prevent the patient from getting further cancer treatments. They have to actually discontinue treatments, and that can be lethal. So there is a large morbidity component, but there is also a mortality component that is being discussed among all these shareholders. The problem with the codes we have currently are they are not a lot, and it does obviously add up. So if you're talking about daily treatments for 6 weeks, that definitely adds up, and that might be a one way of thinking about clinical practice building, because it'll be a service that the dentist, who's always been rather on the sidelines for cancer care, at least direct cancer care. We do clearances now before anyone goes for radiation chemo, but we have never been directly involved with cancer care treatments unless it's oral cancer in some form or salivary gland. So I think this is a great opportunity for the dental profession to step up to the plate and emphasize that not only oral health as a part of general health, but also that we can contribute as professionals to something more mainstream medicine can provide. So whether it's a medical code, a reimbursement code, or a dental reimbursement code, I think is a moot point, because we will be a part of the medical care system.
Dr. Arany, it sounds like there's still quite a few people who need to learn about laser therapy. What do you think can be done to increase the awareness of photobiomodulation?
The human body is using light every day, whether it is sunlight and vitamin D metabolism, or the very ability to see this webinar, vision, right? We are using visible light, converting it into a signal in our eye, the retina, and we can see the physical energy in a biological signal. So it is not completely out of the realm that the human body can use light. So when you start with that, you take away a lot of well-thought. I started this research because I did not believe light could do anything in my patients. And I'm like, no way can, shining light on people make them better. That's not going to happen. But sure enough, my first human clinical study showed improved healing of alveolar extraction sockets. And that's what got me started in this field. It was disbelief that light can do anything. So I think that is a very, very big barrier for professionals as well as laymen who hear about this treatment for the first time. But after you have crossed that barrier, there is another confounding factor, which is a plethora of online material that points in every which way, every which direction. So navigating through that has been challenging, and not everyone is going to do a PubMed search and find the latest scientific report. So the blogs are great because they provide a lot of anecdotal evidences, but finding the right resource for photobiomodulation or low-level light treatment literature has become critical. A lot of the manufacturers are doing great work by providing a list of references for every claim or every suggested use of this device. So that also goes a long way. And a lot of academicians and professionals are either consulted or work directly with them to try and curate that list. Besides all of this exploration, there has to be more organized training. And we talked about either basic dental or medical training or physical therapy. For that matter, acupuncturists, veterinary medicine, as well as functional medicine, integrative medicine, folks have to be exposed to this literature in an organized manner. While we get to that point, I think webinars and online courses and CE programs is the way to bridge that gap.
Arany, I'd love to hear you talk about some of the other applications that laser therapy can be used for in dental and outside of dental as well.
Another great example of interdisciplinary or IPE, interprofessional expertise, right? So this is where we work as a team. You're working with an oral surgeon, but I can see this expanding to various pediatric oncologists, or, if you see pediatric patients, there will be people asking you if there is something you can do for their child or for their elderly parent. And you will be able to offer another treatment that no one else can. And you might have to inform and update some of your medical colleagues, because this is cutting edge research. These are, papers that are coming out last year. We had the guidelines come out. So you'll have to do a little more diligence, maybe prepare a packet of information that you can pass along for very specific app. And the companies do a great job. Many companies actually have application-specific information that you can share very quickly. Of course, I would recommend you curate it yourself and look at it very carefully in terms of where the evidence is. But what you're confident about, I think that's a great place to start sharing.
Thank you for joining us today, to all of our viewers and to Dr. Arany. We hope to be shining a lot of light on oral mucositis and bringing healing to as many people as we can.